Good morning, everyone. My name is Dr. Madeline Verhovsek. I'm the Chief of Medicine here at St. Joseph Healthcare Hamilton, and I'm pleased to welcome you all to Medical Grand Rounds for today, June 30th, which in fact are our last Medical Grand Rounds of the academic year as we head into the summer. Next slide. And we'll go on to the next slide. We'll start off with land acknowledgement. And we'd like to acknowledge that St. Joseph's Healthcare Hamilton sits on the traditional territories of the Mississaugas and the Haudenosaunee nations and is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinaabe, Mississaugas, and Haudenosaunee that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. And as we all go off and hopefully get to enjoy the great outdoors during the beautiful Canadian summer, it's a good time for us to reflect on the peoples who have lived on and shared this land for many thousands of years prior to European settlers arriving. Next slide. So we're really excited to have Dr. Lonnie Pyne with us here today. I'll just put in my own personal note. Lonnie has been one of the kind volunteers who's been helping out with our Medical Grand Rounds working group here at St. Joe's that we've just launched over this past year, and he has made really important contributions to the discussion and to the work around making our Medical Grand Rounds as effective and enjoyable for everyone as possible. And without any further ado, I'm going to hand more of this intro over to Dr. Chris Rabat. And Dr. Rabat is our head of service for nephrology here at St. Joe's. So it's great to have you here, Chris, and Chris is joining us today on a day off, which is just showing the depth of his dedication to his group. So over to you, Chris.
Thank you, Madeline. Good morning, everyone, or the foolishness of my approach, I guess. It's an easy task to introduce Lonnie, as he's been in town, believe it or not, 8 years, having come to us from Western and done his internal medicine training, nephrology training, and subsequent clinical scholar years here in Hamilton, completing his master's in research methodology. So congratulations, Lonnie. His official start date with us is tomorrow, July 1st, and we actually may be putting him to work. He's well on his way into fulfilling the academic mission, numerous research, participation, publications, and a broad array of educational involvement and initiatives. So join me in welcoming Lonnie officially after being in line for 8 years or so in Hamilton, and listening to him attentively on what really may be an important topic. Lonnie, take it away.
All right. Thanks for that, Chris. So my topic is going to be, does hypertension cause kidney disease? Broad idea being a lot of what we attribute to hypertension caused kidney disease is likely related to renal microvascular disease, where the hypertension is consequence rather than cause of the kidney disease. So there's a conflict of interest. I have a co-applicant on some CIHR grants, some research funding as a co-applicant for Dravinsky Research Institute, and as part of my aforementioned master's, looking at some secondary analyses from the COMPASS trial, which was sponsored by Bayer. Aside from that, no conflicts of interest to declare. So objectives, we're going to review the relationship between hypertension and kidney function from epidemiological studies, genetic studies, as well as some relevant clinical trials, meta-analyses of blood pressure lowering trials, as well as the probably 3 most relevant kidney-specific blood pressure lowering trials being MDRD, ESCAPE, and ASK. And we're going to talk about the implications from this information for patients and beyond. We're going to start with the conclusions. I'm going to show you where we're going to end up and hopefully convince you of that along the way. So in terms of conclusions, hypertension and kidney dysfunction are strongly associated, but ultimately the real question is this relationship causal? Is it the case that elevated blood pressure induces microvascular injury of the kidney, causing kidney damage, where hypertension is the cause of kidney dysfunction? Or is it the case that there is an otherwise unknown process going on that causes microvascular injury of the kidney, and as a consequence of that microvascular injury leads to elevated blood pressure, where hypertension is the consequence of the kidney disease rather than the cause? Meta-analyses of blood pressure lowering trials consistently do not show a benefit. Genetic studies consistently show hypertension does not lead to kidney dysfunction. There are a number of blood pressure lowering trials in chronic kidney disease, as mentioned, ESCAPE, MDRD, and ASK, where blood pressure lowering actually does improve kidney outcomes, but only in the proteinuria. In terms of the mechanistic theory as to why, proteinuria likely identifies a hemodynamically susceptible glomerulus, where, similar to the effect of RAS blockade, blood pressure lowering is beneficial, but only if they already have established proteinuric chronic kidney disease. And from animal studies, it appears that proteinuria may be reflective of an impaired myogenic reflex, which we'll go over a bit more. In terms of hypertension emergency, it very well may be the case that extreme elevations, and likely is the case that extreme elevations of blood pressure do induce kidney damage, but these are likely rather rare, rather than as common as hypertension-attributed kidney disease. And even in the setting of hypertensive emergency and AKI, need to consider whether or not that hypertension is cause or consequence of the kidney injury. The renal microvascular disease in many ways is the black box of nephrology. We can see its effects, but we don't know where it comes from. This has important implications for blood pressure lowering and the field more broadly in terms of setting an appropriate research agenda. And I think there's a hopeful future in terms of that research agenda, but I think the first step is to disabuse ourselves of the notion that hypertension is a common cause of kidney disease. Hopefully I will convince you of these things. So first important point of clarification, hypertension is incredibly important modifiable cause of cardiovascular morbidity and mortality. I am in no way calling into question whether or not hypertension contributes to stroke, retinopathy, peripheral vascular disease, cardiovascular disease. I'm specifically directing a somewhat skeptical gaze towards the relationship between hypertension and kidney failure. So kidney function and blood pressure. There's an intimate relationship between kidney function and blood pressure. The kidney needs to operate within a wide range of mean arterial pressures. As you can see here, there is an autoregulatory range where predominantly through this myogenic reflex, where you'll get actually vasoconstriction or vasodilation, renal blood flow will be preserved over a wide range of mean arterial pressures. But that does not mean that the kidney is completely immune, or does not mean that there isn't a very well-described relationship between high blood pressure and kidney disease. So in terms of what is the burden of hypertension-attributed kidney disease, you can see here data from Canada, most recent data from 2011 to 2020. Renal vascular disease, this is incidence, so new cases of end-stage renal disease in terms of what is attributed to renal vascular disease, umbrella term that oftentimes will be attributed to hypertension, is around 10 to 15%. Under here, unknown or not reported, you'll see another about 10 to 15%. In terms of American data, once again, for the most recent 10 years where data is available, in terms of incident end-stage renal disease, 28.6% is thought to be caused by hypertension. So clearly there's a large burden of not just chronic kidney disease, but incident end-stage renal disease caused or attributed at present to hypertension. So what does this usually look like? Patients with hypertension, they are usually non or minimally proteinuric chronic kidney disease. They have no other identifiable cause of chronic kidney disease. Pathologically, what does this look like? Well, we have microvascular disease, namely intimal thickening. There's glomerular sclerosis, so focal global and focal segmental glomerular sclerosis. You can get solidified glomeruli, where the whole glomerular tuft is replaced by matrix material, or you can get an obsolescent glomeruli, where there's tuft retraction and collapse, and Bowman's space is replaced by collagenous material. And you get resolved interstitial fibrosis and tubular atrophy, markers of chronicity. Namely, summarizing, it's microvascular scarring and atrophy. Here you can see an example of microvascular disease of the kidney, with intimal fibrosis and medial thickening of an arteriole. Here you can see a lower power where you can see some medial thickening of arteries, as well as some global glomerular sclerosis with a solidified glomeruli and on a background of interstitial fibrosis and tubular atrophy. So in terms of theories, one, which is the hypertension hypothesis, is to say that hypertension is the cause. Another is to say there's a microvascular hypothesis where there's microvascular disease is the primary mover. Hypertension hypothesis states hypertension causes renal microvascular disease, which leads to chronic kidney disease and end-stage renal disease and the pathologic lesions that we saw. In other words, hypertension is the cause of kidney disease. Alternate explanation is there is renal microvascular disease caused by mechanisms other than hypertension, which leads to chronic kidney disease and end-stage renal disease. And as a consequence of this microvascular disease involving arterioles of the kidney, leads to hypertension. What are these potential other mechanisms? Well, there's really underexplored, but things that have been proposed: aging, obesity, inflammation, oxidative stress, APOL1, which is a particular genetic predisposition common to people of recent West African ancestry. An area that I'm particularly interested in is low HDL, as well as others, and many that we probably have a very, very incomplete understanding of. In other words, microvascular disease is causal, and hypertension is the consequence. Important to keep in mind, these are not necessarily mutually exclusive. There could be a combination of the two. So well-known, well-established, microvascular renal artery stenosis is a known cause of secondary hypertension. There's macrovascular renal artery stenosis, an upregulation of renin-angiotensin-aldosterone, and as a result of those, hypertension. Similarly, if you think of microvascular renal artery stenosis affecting the arterioles of the kidney, the same process, the same pathology is at play, where there is a compromise of arterial blood supply to the kidney, and as a consequence, all of the things that lead to activation of the renin-angiotensin-aldosterone system. In other words, it's very similar to renal artery stenosis, albeit distributed and on a microscopic scale, and causes hypertension. So talk is, does hypertension cause kidney disease? But the other broad question is, does kidney disease cause hypertension? Kidney disease being namely renal microvascular disease of an unknown etiology. Could there be other processes at play besides hypertension, and maybe the hypertension, rather than being cause, is actually consequence? Ultimately, what we're trying to figure out is, what is the relationship between our exposure of interest, hypertension, and our outcome, kidney disease? Does hypertension causally lead to kidney disease? Problem here is people with higher blood pressure are different in ways, people with lower blood pressure in ways beyond just blood pressure. There can be differences in age, sex, socioeconomics, diet, body mass index, smoking, comorbidities, physical activity, a wide variety of other relationships at play here. In addition, there's the potential for reverse causality, where kidney disease, as we talked about, could lead to hypertension itself. In other words, it's complicated. Here's an example of a causal diagram trying to link all of the things that could potentially relate systolic blood pressure to decreased kidney function. Bunch of different causal areas back and forth. In other words, complicated. Another attempt at it, relating hypertension to cardiovascular disease, to decreased kidney function. In other words, complicated. Now, how do we tame this complexity? What's the best way we've come up to do that? Well, it's randomization. What we'd like to do is randomize and assign people to a target blood pressure. And what we want to do is look at randomized controlled trials that randomize people to a different blood pressure target and see what was the effect on kidney function. Important thing to keep in mind here is what the ideal analysis here is intention to treat, not an as treated analysis, because if you analyze people to their achieved blood pressure, you risk reintroducing all of those biases that we were just discussing. So ultimately, what we want to see is a study looking at where there is a randomized assigned blood pressure and see what were the kidney outcomes. We want to do that to avoid all of these ways in which blood people will differ more than just on the basis of their blood pressure. We know that their age, sex, and socioeconomics and diet will not have played the role in determining their blood pressure if we randomize and assign their blood pressure. So There's been a multitude of blood pressure lowering trials, many blood pressure lowering trials. However, a few of these trials were specifically designed for kidney outcomes. We'll get to a few of those later, but the overwhelming majority were not designed to look at kidney outcomes. Consequently, there's very few kidney events in any one randomized controlled trial. There's a clear role here for meta-analysis. And these meta-analyses have been done. This is one in particular, published in The Lancet in 2016. What they did was they took all randomized controlled trials they could find blood pressure lowering interventions involving at least 1,000 patient years of follow-up in each study arm. What they found was 123 studies with over 600,000 participants. In those that actually reported renal failure, they found 16 studies with approximately 80,000 participants. Renal failure was defined as traditionally as end-stage renal disease resulting in dialysis, transplant, or death. It was a total of about 1,700 renal failure events. In other words, about 2% of participants in the studies that reported it. So here we see usual forest plot, 6 different outcomes, intervention and control, and we see the relative risk reduction per 10 millimeter reduction in systolic blood pressure. We've got 5 outcomes that are decidedly beneficial and 1 outcome decidedly not. What do we see? Major cardiovascular events. You lower blood pressure by 10 millimeter mercury, you get a relative risk reduction of 0.8. Great. Coronary heart disease, as expected, 0.83. Stroke, once again, the clinical outcome consistently most strongly associated with blood pressure lowering, along with heart failure. Over here, we have even all-cause mortality. As mentioned, cardiovascular events, an important modifiable risk factor is blood pressure reduction. Now, what's the one left out where it looks like 10 millimeters of reduction in blood pressure has no effect on that event? Kidney failure. Blood pressure lowering did not seem to have any appreciable effect on kidney failure, as opposed to all the other cardiovascular outcomes outlined. So potential criticisms: duration. Maybe it takes much longer to exposure to high blood pressure to detect any renal effect. Many of these trials had about average follow-up of 3 to 5 years. So maybe there may be something there, but 3 to 5 years is, a decent amount of time. And I think I wouldn't necessarily put a lot of faith in this criticism, but I think there's other ways to get around this. So one way to look at this is, how about studies of lifelong exposure? So genetic studies are particularly interesting in terms of assessing causality, because in many ways we are randomized at birth through the effect of meiosis to a random genetic assortment of what was available to us. So rather than randomizing and assigning blood pressure by an intervention, we can look at genetically determined blood pressure and try to assess causality that way. Now, this is a very much oversimplified view of it, but it gets around a lot of the biases that can be introduced by the observational literature, just looking at people with different blood pressure. So what we want to see is, looking at someone's genetic predisposition to blood pressure, to higher blood pressure, does that confer an increased risk of kidney disease or not? And once again, this is going to be a lifelong exposure, because that's kind of how genetics works. Avoiding all of these different biases, because your genes for blood pressure aren't going to determine whether or not you are smoking or physically active, or what's your BMI and diet and everything else. So the underlying question being, do genetic polymorphisms that raise blood pressure cause kidney disease? Does high blood pressure cause kidney disease? There's been a multitude of studies on this, looking at genome-wide association studies, Mendelian randomization studies, a variety of different methodologies looking at, these are genes that increase someone's blood pressure. Does this lead to kidney failure? And they've been pretty remarkably consistent. So this is from Nature in October 2011. Conclusion of the authors was, a risk score derived from variance was significantly associated with blood pressure-related organ damage and clinical cardiovascular disease, but not kidney disease. Just draw your attention to the p-values here by way of positive control. For every increase in genetically determined blood pressure, there was an increased risk of stroke. You can see, statistically significant p-values here. There was an increase for coronary artery disease. However, when you actually look at kidney outcomes, nada. No effect on prevalent chronic kidney disease, no effect on microalbuminuria, nothing. You had higher genetic risk of high blood pressure. increasing your risk of cardiovascular disease and not increasing your risk of kidney disease. Similarly, when looking at continuous measures, whether it be serum creatinine, eGFR, albuminuria, even when using a more sensitive measure as continuous eGFR, no effect. Higher blood pressure did not increase the risk of, did not have any relationship with kidney function. Similarly, another one here, similar methodology. Once again, for every increase in genetically determined blood pressure, there was a significant increase in cardiovascular events, whether they be people of African or European ancestry, and there was no signs of any relationship to chronic kidney disease. Once again, using eGFR slope, urine protein creatinine ratio, no relationship between increased genetic predisposition to high blood pressure and kidney disease. So genetic polymorphisms that increase blood pressure do increase the risk of cardiovascular disease. This is sort of, I think, should lend us greater credence to the actual methodology as by way of positive control. And genetic polymorphisms that increase blood pressure do not increase the risk of kidney disease. So in essence, what we're getting here is what some people have called the triangulation of evidence, where we get multiple lines of evidence, particularly those lines of evidence best equipped to make a causal statement in terms of whether or not high blood pressure causes kidney disease, namely meta-analyses of blood pressure lowering clinical trials, as well as genetic studies. They are pointing consistently in the same direction, which is there is not a causal relationship between elevated blood pressure and kidney disease. However, I think it's important that there are important caveats here, and looking at the kidney-specific literature, we will get to some of these caveats because it is a little bit more complicated than that. So, skeptical viewpoint, no trial of blood pressure lowering has ever demonstrated a benefit on kidney outcomes. I do not think this is true. We'll go through 3 trials where this is not the case, namely ESCAPE, MDRD, and ASK. They did have a benefit, but it was specifically in those with established proteinuric chronic kidney disease, and there was consistently no benefit for blood pressure reduction in the non-proteinuric. So first one up, the ESCAPE trial, published in New England Journal in 2009, blood pressure control and progression of renal failure in children. So they took about 500 children, randomized them of age 3 to 18, randomized them to different blood pressure goals. Given that it was pediatrics, it was based on age and height standardized definitions of high blood pressure. So the intensified target was a map below the 50th percentile for their age and height, and conventional blood pressure target map of 50 to 95th percentile. Both arms, there was equivalent dosing of ramipril to eliminate any beneficial effect of RAS blockade. And the outcome was a 50% decline in GFR or end-stage renal disease, traditional kidney outcome. This is table 1, 2 things I'll just point your attention to. Average age, about 11.5 years old. So rather than children, average was, adolescent. And in terms of baseline proteinuria, the mean proteinuria was about gram and a half per day. So the overwhelming majority of participants were proteinuric. And what do we see? Lo and behold, beneficial effect. Intensified or lower blood pressure group had less end-stage renal disease, doubling of serum creatinine, than did the higher blood pressure target. As you can see here, hazard ratio of 0.65. So 36% in the conventional arm and 25% of participants in the lower blood pressure, intensified blood pressure arm. However, what it appears is that there appeared to be a differential effect by baseline proteinuria. Now, any subgroup analysis is going to be underpowered for things like this, but just drawing your attention to it. As you can see here, in those with half a gram to a gram and a half, or those with greater than a gram and a half of proteinuria per day, significant benefit. And in those with minimal proteinuria, at least point estimate was the confidence interval quite wide. There was no real, there was not a ton of events in the non-proteinuric. What I'll draw your attention here is the p-value for interaction. So it's an underpowered test, but it did look like there was a differential effect based on the non-proteinuric as compared to the proteinuric, where it didn't look like there was a signal for beneficial effect in the non-proteinuric for blood pressure lowering. So blood pressure lowering improved kidney outcomes, but most participants were proteinuric at baseline. And there was a signal for less effect, potentially no effect, in those without proteinuria. Now, Criticism of this might be, this is pediatrics. Well, I'm an adult nephrologist. Is this really of relevance? I would say yes. So at the risk of offending pediatricians everywhere, I'm going to make the argument that children are small adults, or more specifically, adolescent kidneys are really just small adult kidneys. You're born with all the nephrons you're ever going to have. The difference between the kidney of an 11.5-year-old and an adult is about a couple centimeters of non-nephron tissue. I'm going to go with these are small adults. I think this is a relevant line of evidence for our discussion here today. At the very least, I don't think this should be ignored because this is decidedly a blood pressure lowering trial that showed benefit for kidney outcomes, albeit I think specifically or much more strongly in the proteinuric, those with established proteinuric chronic kidney disease. So how about blood pressure lowering trials in adults? There's two, probably the two most famous ones and probably the two best ones, MDRD, which is modification of diet and renal disease, and ASK, African American Study of Kidney Disease and Hypertension. So MDRD initially published in 1994 in the New England Journal. There was two studies with participants of different baseline kidney function, study 1 and study 2, which was slightly lower GFR in the other study, but basically randomized to the same intervention, which was a map of 92 versus a map of 107. Outcome was looking at GFR slope, trying to see whether or not targeting a lower blood pressure will slow the decline in kidney function. So the primary analysis of this showed no statistically significant effect of lower blood pressure target on kidney outcomes. However, what we want to look at here is, was this modified by their baseline proteinuria status? Are we seeing consistent findings similar to what we saw in the ESCAPE trial, where it's beneficial in those with proteinuric chronic kidney disease and possibly neutral or no effect in those with non-proteinuric chronic kidney disease? And that's kind of what we're seeing. So here's, you can see the baseline proteinuria in the study A and study B, or study 1 and study 2, about 30 to 50% were minimally proteinuric, and about 10 to 15% had over 3 grams per day. So wide range of baseline proteinuria in the participants in MDRD. What we see here, I'll just orient you a little bit. On the left here, we have study A, and on the right here, we have study B. For all intents and purposes, they have basically the same findings. On the x-axis, we have baseline urine protein, so from the non-proteinuric all the way to the heavily proteinuric. And on the y-axis, we have what the effect is on the rate of GFR decline. We have the black dot, which is usual blood pressure, and the unfilled, which is the intensive blood pressure lowering. What you see in both study A and study B, in those without any proteinuria, the GFR decline was the same, regardless of whether or not you were in the lower blood pressure group. And as you increase the proteinuria, you'll find that there is a beneficial effect in terms of decline in kidney function, the slope in terms of mils per minute per year, to the point where in those with heavy proteinuria, the standard blood pressure arm was losing GFR at upwards of 13 mils per minute per year, which is huge. And the decline was 8 mils per minute per year. Still a huge effect, but definitely an improvement in the lower blood pressure group, specifically in the proteinuric. So consistent with the findings of the ESCAPE trial, we're seeing a beneficial effect of blood pressure lowering specifically and only in those with proteinuria. And this is just graphically displaying it. You can see the dotted and solid line for higher blood pressure and lower blood pressure. And you can see in the minimally proteinuric, less than a gram per day, really no difference. In the 1 to 3 grams, starting to get a divergence in the decline in kidney function over time. And in the heavily proteinuric, and a beneficial effect of blood pressure lowering. So how about longer term follow-up in traditional kidney failure events? Here we can see a long-term follow-up from 2005. They combined the two studies. What the actual, now what they were randomized to was a MAP target, but what the actual achieved blood pressure difference was in the lower blood pressure group was 126/77 versus 134/81 in terms of like the actual achieved blood pressure separation between the two arms. What do we see in terms of the traditional kidney outcome? We see an improvement where the lower blood pressure arm had less doubling of serum creatinine and end-stage renal disease as compared to the higher blood pressure target. Hazard ratio of 0.68, statistically significant. So beneficial effect of blood pressure lowering. How about by proteinuria? I'll just draw your attention to the black dots here, which is the kidney failure. What you see in and around the null effect is those with little to no proteinuria. And as you go down, a increase in effect in terms of the benefit of blood pressure lowering on reducing kidney failure. More proteinuria, more beneficial effect. Once again, these are subgroup studies, or these are subgroup effects. They're going to be underpowered, but the p-value for interaction was 0.09, not meeting conventional statistical significance, but once again, pointing in the same direction as other studies, looking like blood pressure lowering is beneficial in those with established proteinuric chronic kidney disease and not beneficial in those without proteinuria. So blood pressure lowering seems to be beneficial in the proteinuric, does not seem to be beneficial in the non-proteinuric. Now, the problem with this study is it occurred in 1994, which meant that if you randomize people to two different blood pressure arms, you're going to get differential ACE inhibitor usage. This in 1994, this was not standard of care. We now know that specifically in the proteinuric, ACE inhibitors and ARBs confer kidney benefit. So the problem being that the lower blood pressure arm required more blood pressure lowering drugs, and they got exposed to more ACE inhibitors, 34% versus 54%, about a 20% difference. So the lower blood pressure arm had 20% more exposure to ACE inhibitors than did the higher blood pressure arm, which begs the question is the blood pressure lowering beneficial, or are they just getting more RAS blockade? Which we now know, with the benefit of hindsight, is beneficial, irrespective of blood pressure lowering. So greater use in the ACE inhibitor, a greater ACE inhibitor use in the lower blood pressure arm. Are we seeing blood pressure lowering effects, or are we seeing ACE inhibitor effect? So one study that was particularly well equipped to answer this question was the ASK study, which was done after 1994. So it's the African American study of kidney disease and hypertension. So we have hypertension attributed chronic kidney disease is much more common in African Americans. The trial was designed to assess what is the appropriate blood pressure target in African Americans with hypertension attributed chronic kidney disease. It was a factorial trial, so there was also an agent arm where patients were randomized to ramipril versus amlodipine versus metoprolol. So the blood pressure target arms had equivalent exposure to ACE inhibitors. So here we have the initial trial results from 2002. If everybody could mute, I think we got some feedback from somebody. So we have about 1,100 participants, all African-American, with hypertension attributed chronic kidney disease. And in terms of a case definition, they were required not to have heavy proteinuria. In other words, what the investigators would likely attribute to hypertension, hypertension attributed chronic kidney disease. So these are a specific patient population where we said, we think their kidney disease is from hypertension. They're randomized to a lower blood pressure target, a MAP of less than or equal to 92 millimeters of mercury, or usual blood pressure target, MAP of 102 over MAP of 102 to 107 millimeters of mercury. And the outcome was GFR slope. So here we can see baseline information in whether it be the lower usual care. You see equivalent exposure to ACE inhibitors, 38% in both arms. So taking care of one of the potential criticisms of MDRD. And you can see average proteinuria of about 0.5 gram per day. So not heavily proteinuric by any means, very much what you would expect for a hypertension attributed kidney disease population. What do we see? This is a decline in GFR over time. You see an acute decrease with lower blood pressure, which is always the case. And ultimately, it looks like there's really not much in the way of the separation of arms in terms of their change in GFR from baseline. So irrespective of the lower blood pressure goal, it looks like those with hypertension attributed kidney disease did not really derive any benefit from the lower blood pressure. However, so the overall trial results were not statistically significant, but was this effect modified by proteinuria? And what about long-term follow-up? So that was answered by a long-term follow-up of the ASK study published in the New England Journal in 2010. So they randomized, or not randomized, they analyzed it according to baseline proteinuria. Those with little to no proteinuria, a UPCR of less than 0.22, you can take that as non-proteinuric, to those that have at least mild proteinuria, a urine protein creatinine ratio of 0.22. When you separate those two, you get minimal proteinuria in this group here and about 1 gram per day in the UPCR greater than 0.22. Now, they were randomized to different mean arterial pressures. What was actually the achieved blood pressure separation was about 10 millimeters of mercury, approximately 130 over 80 to approximately 140 over 90 was the actual achieved blood pressure separation during the trial phase. This is the long-term follow-up. So trial phase, systolic blood pressure up top, diastolic blood pressure on the bottom. You can see a separation in the actual trial phase of the study, and in the long-term follow-up, a narrowing of the blood pressure difference between the two groups. So we're looking at the long-term outcomes and how they are different by baseline proteinuria. Lo and behold, what do we see? In those with proteinuria at baseline, we see a benefit of intensive blood pressure control as opposed to standard in terms of doubling of serum creatinine and end-stage renal disease or death. And what do we see in the non-proteinuric? No benefit. Pretty clear overlapping of the high blood pressure arm and the lower blood pressure arm. Intensive control in those with proteinuria at baseline, hazard ratio of 0.73, p-value 0.01, confidence intervals as you can see, and in the non-proteinuric, null effect. Hazard ratio 1.18, p-value 0.16. If anything, the point estimate was for harm from the lower blood pressure, as you can see the black line on top of the dotted line here and the opposite relationship there. So once again, similar relationship. Blood pressure lowering is beneficial if you have established proteinuric chronic kidney disease. Does not seem to be beneficial in those with non-proteinuric chronic kidney disease, even in those with, this was a study specifically designed for people with hypertension attributed kidney disease. Blood pressure lowering did not have an effect. So what do these renal outcome blood pressure lowering studies show us? Whether they escape MDRD or ASK, they're showing the same thing. Fairly consistent finding. Blood pressure lowering is beneficial in the proteinuric. Blood pressure lowering is not beneficial in the non-proteinuric. So some more potential criticisms. Non-proteinuric are always going to be a lower risk group from a kidney perspective. Proteinuria is a potent risk factor for kidney disease progression. Likely we're just seeing they're non-proteinuric, they're not having many kidney failure events, and we're just going to have a low power to detect an effect. We're only seeing an effect in the proteinuric because that's actually having progression, actually having events. Now, this is a potential criticism, but I do not think it is borne out by looking at the data. So let's take a look. What do we see? We see that even in the non-proteinuric from MDRD, GFR is declining at 3 mils per minute per year, which is a pretty healthy rate of decline. That's about 3 times your population average for patients in their 50th, 60th decade of life. So they're declining 3 times faster than unselected patient population. So there's plenty of progression happening. That progression is just not meaningfully impacted by blood pressure lowering in the non-proteinuric. Similarly, if we look at the ASK study in the non-proteinuric, there is plenty of progression. There is a straight up depressing amount of progression happening. At 10 years, 30% of participants have end-stage renal disease, doubling of serum creatinine. And there are events happening, as you can see. The distinction is not that there is a lack of events. The distinction is these events are not meaningfully impacted by blood pressure lowering in the non-proteinuric. So putting it all together, proteinuric patients with chronic kidney disease derive benefit from blood pressure lowering. The non-proteinuric do not appear to derive benefit from blood pressure lowering. You're required to have a certain type of CKD to derive benefit from blood pressure lowering. In other words, hypertension does not cause kidney disease. Hypertension contributes to the progression of a certain type of established kidney disease, namely proteinuric chronic kidney disease. You already have to have proteinuric chronic kidney disease in order for blood pressure to be high blood pressure to be actually be contributing to progression. So looking like blood pressure does not cause kidney disease. Now, I think it's fair to say, this doesn't make a whole lot of sense. So you're telling me that elevated blood pressure causes kidney damage, but only in the proteinuric? Yeah, I think so. I think that's a pretty consistent finding from the studies that we've seen and in the range of blood pressure control in those studies. So argument from analogy, this is exactly the relationship we see from RAS blockade in chronic kidney disease. Whether the use of ACE inhibitors or ARBs, there's benefit in the proteinuric, little to no benefit in the non-proteinuric. As an example, here's a meta-analysis of a number of studies of RAS blockade, where you have baseline urine protein excretion on the x-axis and relative risk for doubling of serum creatinine or end-stage renal disease. Lower proteinuria, effect approximating 1 or null effect, greater effect in terms of relative risk reduction for the more heavily proteinuric you are. Benefit in the proteinuric, little to no benefit in the non-proteinuric. Similarly, this is just displaying it graphically. In those with proteinuria at baseline, there was, so the black bar is treatment with RAS blockade and the white bar is control. Clearly a significant benefit in terms of end-stage renal disease, doubling of serum creatinine with RAS blockade in those with proteinuria, and similarly, no beneficial effect, no difference in the RAS blockade treated versus untreated in those with little to no proteinuria, so less than half a gram per day. So in terms of the mechanistic theory for why this could be the case, proteinuria likely reflects hemodynamic stress, namely intraglomerular hypertension. Proteinuria may be indicative of a loss of a protective effect of that myogenic reflex. Animal studies show that the degree of proteinuria approximates the degree of the blunting of that myogenic reflex, the vasoconstriction or vasodilation of the renal artery, renal arterioles in response to systemic blood pressure. Proteinuria indicates likely benefit from interventions that decrease intraglomerular pressure, whether that be RAS blockade, targeting that efferent to afferent arteriole and causing a reduction in intraglomerular hypertension, or by reducing systemic blood pressure more broadly in those that are predisposed to it with established proteinuric chronic kidney disease. This is a potential mechanistic theory for why RAS blockade and systemic blood pressure lowering seem to show the same relationship, which is if you're proteinuric, you derive benefit. If you're not proteinuric, it doesn't seem like you do. Once again, this is just another demonstration of that autoregulatory range and effect of the myogenic reflex. So proteinuria is reflective of an underlying type of renal lesion that renders the kidney susceptible to damage induced by systemic blood pressure. Outside of this pre-existing type of lesion, the kidney appears fairly well protected from the potentially harmful effects of elevated systemic blood pressure. Proteinuria is required for hypertension to have a deleterious effect on kidney function. In other words, people have to already have kidney disease in order for blood pressure to cause kidney, elevated blood pressure to be causing kidney damage. Now, arguments against this: the trials are too short, the patients are all low risk, and we have too few kidney failure events and low power to detect effect. As mentioned, the trials have 3 to 5 years of follow-up, and the meta-analyses have 1,700 events. This is not a case of not a lot of events. We have events, they're just not meaningfully impacted by blood pressure lowering. And in terms of duration, we have genetic studies which are consistent, saying that genetically susceptible, genetically determined risk of high blood pressure does not increase your risk of kidney disease. And we have plenty of progression and events in MDRD and ASK, as mentioned, as previously outlined. So not lack of events, lack of effective blood pressure lowering. So could there be a threshold effect? Is this a potential argument against? Could proteinuria reflect increased susceptibility to blood pressure-induced kidney damage? Could the elevated blood pressure still be harmful in the non-proteinuric? It just requires significant elevations of the blood pressure above the autoregulatory zone. I think this is likely to be the case. It's difficult to have any argument for that from the data that we reflected, just because we don't have patients who are coming in with a systolic blood pressure of 180 or 200 in these trials. What we actually saw in MDRD, what the difference in blood pressure was, as you can see, 126 systolic versus 134. In ASK, the actual achieved blood pressure difference, 130 versus 140. And in ESCAPE, it was a pediatric trial for percentile blood pressure. So we're not seeing people with, blood pressures above that autoregulatory zone, systolics of 180, 120, or 200. So from the meta-analysis, really not seeing a whole lot in terms of what the effect of kidney failure was in those with baseline blood pressure greater than 160. Very few studies, very few events, a total of like 59 events, huge confidence intervals. So you really can't make any conclusions from this in terms of, is there a threshold effect above which extreme elevations in blood pressure cause kidney damage, which I think is likely to be the case, but can't really get that from these meta-analyses or clinical trials. So is there a threshold effect? What about the effect of malignant hypertension, extreme elevations? Difficult to assess this with available clinical studies and genetic studies. Very well may be the case that there is a threshold effect in non-proteinuric, where extreme elevations in blood pressure cause kidney damage, possibly above this autoregulatory range, above this map of 170. Possibly it is be above this range where maybe you'll see extreme elevations of blood pressure causing kidney damage. Ultimately, can really neither prove nor disprove this threshold effect with these studies, but personal opinion, yes, I believe that's likely the case. So briefly, just to touch on hypertension emergency and acute kidney injury, even in the setting of AKI and hypertensive emergency, you can't really escape the old chicken and the egg that was the title slide. I think trying to tease apart what's cause and what's consequence is still very much of relevance here. So I think we still need to have caution in attributing kidney disease to hypertension in the setting of hypertension emergency and AKI. Many conditions will present with an AKI and hypertension. Hypertension may be the cause of the AKI, or hypertension may be a consequence of the AKI. Atypical HUS, scleroderma renal crisis, a variety of different glomerular diseases can present where the initial inciting event is a primary glomerular disease that, as a consequence of it, produces hypertension. So it's important to take care to not overly zealous attribute the AKI to their hypertensive emergency, and to keep a broad differential in mind. That's the brief little aside for AKI and hypertensive emergency. So arguments against hypertension doesn't cause kidney disease. You might take a nihilistic approach and say, who cares? Does this really matter? You might say, you know what, Lonnie, I see a lot of patients in clinic, 70 to 80 years old, their eGFR is 20 to 30, they have no proteinuria. Who cares what I call it, whether it's hypertensive nephrosclerosis, hypertensive nephropathy, hypertension attributed kidney disease, ischemic nephropathy, renal microvascular disease. I focus on blood pressure reduction because it's one of the few useful things I can do for these patients, useful from a cardiovascular event reduction. Honestly, I have some sympathy for this point of view for this particular patient archetype, but I think there are important implications for this evidence beyond these individual patients and for the field as a whole. There is, as we've seen, plenty of hypertension attributed chronic kidney disease, resulting in a large burden of end-stage renal disease. And as we've seen, we see progression of this chronic kidney disease despite blood pressure control in ASK and MDRD. Question is for the field as a whole, what mechanisms are we missing by focusing on, saying that this is from blood pressure, elevated blood pressure? And are these mechanisms shared beyond hypertension attributed chronic kidney disease? These renal microvascular lesions that are characteristic of what we attribute to hypertensive nephropathy are very common outside of hypertension attributed kidney disease. They're very common in diabetic kidney disease. Could these mechanisms of progression also be at play in diabetic kidney disease? I think it's worthy of additional investigation. Once again, we have the hypertension hypothesis and the microvascular hypothesis. Hypertension is cause, hypertension is consequence. I think these sorts of things, particularly low HDL, something that I've become interested in, that could cause renal microvascular disease, need further attention, need to be prioritized in our sort of research agenda more broadly. So I think this renal microvascular disease is the black box of nephrology. We see the effects of it. We don't really know what the cause is. As I've hopefully convinced you, it's on dubious grounds to say all of these lesions are from elevated blood pressure. Once again, we can see its effects. We can see its effects pathologically from renal microvascular disease. We can see its effects in terms of progression of kidney disease, 30% at 10 years with end-stage renal disease in ASK. But we don't know what it's from. So these vascular lesions are common beyond hypertension-attributed kidney disease. This has important implications for counseling the individual patient in front of us. If they're heavily proteinuric, an additional benefit of blood pressure, getting blood pressure under control appears to be nephroprotective effect. If they are not proteinuric, I think you're on shaky ground to say, I'm decreasing your risk of kidney failure by improving your blood pressure control. As I mentioned, cardiovascular events, more than good enough reason to get their blood pressure under control. But you're on shaky grounds to counsel them to say, I'm decreasing your risk of kidney failure by getting your blood pressure under control if they are non-proteinuric. And I think this has important impact for the field as a whole in terms of setting a scientific agenda. If hypertension is the cause of a large amount of chronic kidney disease and end-stage renal disease, we need translational science, we need implementation science. But if there are alternate mechanisms at play where hypertension isn't the cause of the kidney disease, our scientific needs are very, very different. We need a better mechanistic understanding and eventually evolving into intervention trials targeting what may be the actual mechanism of progression causing these renal microvascular lesions. So In conclusion, hypertension and kidney dysfunction are strongly associated, but real question is this causal? Does high blood pressure cause kidney damage, or does microvascular kidney disease lead to elevated blood pressure? Is hypertension cause or consequence of kidney disease? From meta-analyses of blood pressure lowering trials, they consistently do not show a benefit on kidney outcomes. Genetic studies consistently show hypertension does not lead to kidney dysfunction on a broad population level. However, we do have a number of different clinical trials in the setting of chronic kidney disease, namely ESCAPE, MDRD, and ASK, where blood pressure lowering improves kidney outcomes, but only in the proteinuric. Mechanistic theory at play here is proteinuria identifies a hemodynamically susceptible glomerulus. And by way of analogy, this is exactly what's seen with RAS blockade. The mechanism may be impaired myogenic reflex, but I think that's very much unsettled at this point, but that's sort of how things mechanistically kind of make sense to me at this point. In terms of hypertension emergency and a threshold effect, do extreme elevations of the blood pressure above the autoregulatory zone, are they harmful irrespective of proteinuria? I believe that to be the case, but the clinical trials, we don't have clinical trials randomizing people to a systolic of 200 versus not. So you're not going to get high quality evidence to point to this, but I think that is very likely to be the case. But even in the setting of hypertension emergency, I think keeping the idea in mind that the relationship between kidney disease and hypertension is a lot more complicated, and the hypertension that you're seeing may be consequence of the kidney disease rather than cause. And I think at least keeping a broad differential and not having a premature diagnostic closure to say, oh, this is all from the hypertension is important. As an example, scleroderma renal crisis, atypical HUS, they will present with blood pressure every bit as elevated as hypertension, hypertensive emergency leading to an AKI. So important to keep other things in mind. Renal microvascular disease is the black box of nephrology. We can see its effects, but we don't really know where it comes from. I think this has important implications for blood pressure lowering for the individual and for the field more broadly in terms of setting an appropriate research agenda, investigating alternate mechanisms of progression. I think there's a hopeful future here, but I think the first step is to disabuse ourselves of the notion that hypertension is a common cause of kidney disease. And with that, I'd be happy to take any questions.
Thank you very much, Lonnie, for that excellent discussion of a very interesting topic. So we'll take any questions that anyone may have for Dr. Pyne while we're waiting for some questions to come up. I guess my question, when we think about, internal medicine in general or primary care, blood pressure control is a huge part, hypertension screening and initiating antihypertensives. With this conceptualization of things, do you think in any way that changes our practice or our focus on hypertension management? Or as you had highlighted earlier on, hypertension has so many microvascular and kind of impacts as it relates to stroke risk and atherosclerotic disease in the heart, et cetera. So maybe you can just discuss, how does this impact our clinical practice potentially?
Yeah, I want to be very clear. In no ways, please do not take this to say the blood pressure control isn't important. Cardiovascular disease, not to diminish things, but cardiovascular disease is exceedingly much more common and much more greater burden of disease than kidney disease, to be perfectly honest. So it's incredibly important, and none of this should be an argument for relaxing blood pressure control. It's sort of thinking about it from specifically a kidney-centric standpoint, but it is in no way should lead to us relaxing in terms of the importance of blood pressure control from a population or individual standpoint, particularly from cardiovascular disease. This was specifically for the relationship, which I think is a lot more complicated between blood pressure control and kidney disease. I think Chris has got his hand up.
Thanks so much. Yeah, so we've got Dr. Rabat's hand up. Go ahead, Chris.
Lonnie, thanks for that overview. It fits with what my understanding of the subject matter is. What if we called the organ, the end organ in hypertensive damage, the microvasculature rather than any specific organ? Are you aware of whether there are data in other tissues, muscles, skin, for example, that are susceptible to blood pressure and those other confounders and show a similar microvascular process and scarring. So, if I'm smoking and diabetic and aging, will I become sarcopenic and more wrinkly and saggy along with my non-proteinuric chronic kidney disease?
Yeah, I mean, I think that's a good question in terms of whether or not there are alternate models of this. Does the ubiquitous white matter changes that we see on CT scans from seemingly everybody past their 6th decade of life, is this a similar process going on? I think these are important questions, and I think there leads to interesting questions beyond just nephrology. I think part of it too is just relating the fact that a lot of this evidence base is derived from this is the effect that blood pressure lowering or LDL lowering or a number of different interventions have on epicardial coronary artery disease. And I think the first step is to acknowledge renal microvascular disease, and microvascular disease writ more broadly does not necessarily have the same pathophysiology, the same biology at play as epicardial coronary arteries. So I don't know of anything in terms of this area, but I think this is something that's been sort of understudied, and something that I have a particular interest in, because I think it's a lot that we don't understand about it. I mean, fundamentally, I think it's just acknowledging that which applies to epicardial coronary arteries does not necessarily apply to the renal microvasculature or maybe the microvasculature more broadly.
Thanks so much, and thanks for that question, Dr. Rabat. So I think with that, in the absence of any other last minute questions here, we'll look to wrap things up. And once again, huge thanks to Dr. Pyne for pulling together that tremendous review of a huge and very interesting topic. These rounds are being recorded and will be posted on the McMaster Department of Medicine YouTube account within the next few days for anybody who joined late or who would like to watch that again to catch all the details. Things will quiet down through the summer for medical grand rounds, and then the next medical grand rounds will be on September 1st, and it will be a chairs medical grand rounds. So have a fabulous summer, everyone, and I wish you all the best. Take care.